I guess I'm back, but I don't know how to. Hold on. Let me just exit my email. Still? Am I live right now or I don't know. Connetics, I am. So let me share my screen now. Yes, I am live. I'm sorry. Let me just share my screen now. Okay, I guess you can see my screen now, huh? There you go. There you go. Hold on. Let me just exit other stuff here. I know for some reason I can't really see the Facebook Facebook Live. Okay, so I guess if I can't see it, and then I would say that I'm just gonna begin with my lecture. I'm having some technical issues again. Having some technical issues again. Okay, so Ipass processing is also here. Can you say yes so I can proceed now, please? I can see it on my cell phone now, so I guess we're good. We have some 30 yeah, 30 plus viewers as of this moment. I can see it in the Facebook now. Can I get a yes so I can start now? Okay, good. I think they are just clicking the emojis. All right. So by the way, this is my third time here in Connetics College. Again, this is a project, a joint project of Connetics and other review centers for NCLEX at the same time English exam. So this is very much, a free lecture to you guys, an hour or at least more than an hour, to give you again free lectures as part of your journey towards uh, successful exam, your NCLEX. And it's not just, I'm always telling you guys, it's not just about passing NCLEX. It's about being an excellent nurse coming here in the US, wherever it's applicable. If you want to go to Canada, but I guess primarily your Connetics is giving you guys your opportunities to come here in the US. So, well, I'm Jay, and again, I'm from Ipass. I'm representing Ipass to give you a 1 hour free lecture about antibiotic ladder. Antibiotic ladder, that's a pretty much an interesting topic, right? It's not only about NCLEX, but it's also about your practice. If you're practicing in the hospital right now while preparing for your NCLEX, this is very much applicable. All right. And you will have lots of takeaways considering which antibiotics you're gonna give for a patient having UTI, for a patient having pneumonia, or a patient having wounds, for example, considering cellulitis, those kinds of things. All right. And when I say, I think I'm sharing my screen now. When I say antibiotic ladder, what do you mean by ladder, by the way? Ladder means what? Ladder, one step at a time. All right. So one step at a time. So to explain it to you guys, why does it say like ladder or antibiotic ladder? Practically speaking, and it's still happening nowadays, whenever you have colds, for example, and then you are given a very strong antibiotics, what do you expect? What do you expect? Antibiotic resistance. Okay? Because you're not following the ladder. You have to follow the ladder. You have to follow certain antibiotics for at least, common infections. I mean, just a simple infections, not necessarily giving stronger antibiotics. That's why you develop your antibiotic resistance. Okay? And microorganisms associated with your antibiotic resistance are really strong. Okay? To think about it, it should be, you can only see that in the hospitals. You can acquire it from the hospitals. That's why it's called like, hospital acquired infections. But nowadays, if you look at the situation nowadays, hospital acquired infections is defined technically as what? An infection acquired in the hospital from the word itself after being admitted 48 hours to 72 hours or 2 to 3 days. But nowadays you see patients coming to the ER having, for example, MRSA. MRSA is one, microorganisms that is, associated with your antibiotic resistance, methicillin resistant, right? So I mean, they come to the hospital, just came into the hospital within a period of 24 hours, they already have the MRSA. So if you think about it, practically speaking, there's no such thing as uh, hospital acquired infections because they already acquired it from the community. It's not anymore hospital acquired infections. And that's because we are not following the antibiotic ladder. Okay? So I'm going to divide this drawing into two. Okay, I'm gonna draw a line in between. Are you ready? Are we good? So two lines here, I mean two divisions here. I'm gonna put here, I'm gonna make it in blue, gram positive, and this is your gram negative. Okay, shout out. Hi, Mr. Sylvester. Hi, Miss Kring. Thank you for coming today. And this is another free lecture for those who just came in. Anyway, this is gram positive and this is your gram negative microorganisms or bacteria. Okay, so what are the most common gram-positive microorganisms, right? What are the most common gram-positive bacteria? For example, I'm gonna give you Streptococcus. Okay, I'm gonna also gonna give you Staphylococcus. What else? I'm also gonna give you Enterococcus. All right, Enterococcus bacteria. Streptococcus. I'm also gonna put it here. Your Clostridium difficile. Okay, your Clostridium difficile. Okay, we have strep, staph, enterococcus, and C. difficile. Where can you see your streptococcus? Pneumonia, respiratory infections. What about your staphylococcus? It's everywhere. Diba? Staphylococcus can be everywhere in your skin or respiratory. It's everywhere. Okay? I'm talking about also your methicillin-resistant staphylococcus aureus. It can be everywhere. Okay? Staphylococcus. These are the common gram-positive microorganisms. On the other hand, we also have your gram-negative. Now, give me some microorganisms that are gram-negative, bacteria in the microscope. For example, I'm gonna give you E. coli. Okay? I'm gonna give you E. coli. What else? Your ESBL. Your ESBL is a hospital acquired kind of microorganisms as well, including your what? Your Klebsiella. Okay, your Klebsiella. And the famous, of course, Pseudomonas. But here in the US, not much of Pseudomonas. It's most like more common is like your MRSA, your VRE, those kinds of things, ESBL. Those are the common ones here in the US. Have you encountered these kinds of, microorganisms in the hospital? I mean, not acquiring, uh, uh, not acquiring to yourself, huh? Not, no, it's not. I'm not talking about that. I mean, from your patients. Okay, so gram positive and gram negative as well. Streptococcus for gram positive, pneumonia, respiratory infections, enterococcus from the word itself, entero, bowel infections, staphylococcus, and as well as C. difficile, Clostridium difficile. Your Clostridium difficile is, it can cause colitis. It's another form of bowel infection as well. Okay, this is also brought about by antibiotic resistance. Okay, E. coli, gram negative. E. coli is, where can you find this? What infection can you find this E. coli? Can I see your answers here? Where can you find this E. coli? UTI. Okay, UTI. Where can you find your ESBL? It's everywhere. It could be what? It could be coming from respiratory. It could be coming from urine. All right, ESBL means what? Extended spectrum beta lactamase. In other words, resistant to a beta lactamase kind of, antibiotics. Klebsiella. Klebsiella is the most common cause of your pneumonia as well in the hospital. So in other words, hospital-acquired pneumonia. Can you follow? Pseudomonas is everywhere. It could be respiratory, it could be a skin infection, it could be everywhere, it could be bowel, it could be anything else. Okay? So these are the microorganisms that I'm talking about here, the gram-positive and the gram-negative bacteria. Okay, what's the baseline antibiotics? What's the baseline antibiotics? I'm gonna write here your penicillin. Okay, I'm gonna write here your penicillin. That's the basis, right? If you're talking about the ladder, one step at a time. One step at a time. In other words, you're gonna start it at the very mildest antibiotics. I'm gonna start here. In this drawing, we have gram negative on this corner, right? Okay, so here, amoxicillin. I'm just gonna, do I need to write the whole thing? I guess not. Amoxicillin and as well as your ampicillin. All right, your ampicillin and your amoxicillin. Your amoxicillin is in a form of PO. Your ampicillin is in a form of your IV. That's the very baseline. All right, your amoxicillin. If you look at it, amoxicillin, your ampicillin is towards the gram negative. Okay, I wrote it on your gram negative. Okay, that means to say you can give amoxicillin, for a patient having UTI. Later on, I'm gonna tell you the conditions, the infections, and I'm gonna choose what kind of antibiotics this patient can get. Okay, amoxicillin, ampicillin, these are the basic antibiotics that we're giving to our patients. Am I right? Okay. But nowadays, there's lots of microorganisms that are resistant to amoxicillin and ampicillin as well. That's why they added some form of a chemical, which is what we call as your beta lactamase. Okay. So what makes them broad, or which means to say empiric, which covers gram negative and gram positive because of the beta lactamase. So beta lactamase, I'm gonna add here your beta lactamase. Okay, your beta lactamase. And what makes your amoxicillin, again, very effective to your gram positive and your gram negative because of your beta lactamase. That's why you see your clavulanic acid. All right, so amoxicillin plus your clavulanic acid, it's basically your co-amoxiclav, right? That's your brand name. Do you see that in the US as well? You also see that in the US, your co-amoxiclav. Do you see that in the Philippines? Yes, you see that in the Philippines as well. Okay, what about your ampicillin? Your ampicillin plus your sulbactam, that is your unacin. All right, brand name is unacin. Amoxicillin plus your clavulanic acid is co-amoxiclav, and your ampicillin plus sulbactam is basically your unacin. This makes them broad. If you notice, your beta lactamase, it covers your gram positive and as well as your gram negative microorganisms. In other words, If your patient is having some form of an infection because of streptococcus or staphylococcus, your amoxicillin plus your clavulanic acid, does that cover also these kinds of infection if you're having some form of pneumonia because of streptococcal infection? Yes. Okay, you can give that. Again, because it's empiric. It means to say it covers gram-negative and as well as your gram-positive bacteria. Okay, there's lots of microorganisms that are resistant to this beta-lactamase, to this amoxiclav, and at the same time your unacin. That's why we have what we call as your what? What do you think is the next one to this? What do you think is the next level to your amoxicillin and as well as your ampicillin? Because like I said, there's lots of microorganisms that are very, very, very strong, resistant to this kind of antibiotics. Okay, what do you think is next? What do you think is the next to this ladder? Okay, they develop what? Piperacillin. So what's next to you? What's next to your piperacillin? I mean, what's the added solution to your piperacillin? Your piptazo, right? So piperacillin plus your tazobactam. In other words, this is also a form of beta-lactamase. Okay? From the word itself, tazobactam. So piperacillin plus your tazobactam in a form of your Sosin, or sometimes your brand name is Piptazo. In the Philippines, I guess the brand name is, I forgot about it already. I'm sorry. What's the brand name in the Philippines for your piperacillin plus tazobactam? What's the brand name there? Come on. I'm looking at your live, live comments. Your tazobactam and your piperacillin in a form of your Tazosin, I guess it's Tazosin. Your Tazosin. There you go. These are the brand names that are common in the Philippines. Oh, Vigocid, I didn't know that. So Tazosin, there you go. Sosin, which our hospital is using. Some hospitals are using Piptazo. So I'm not sure in UK they're using Piptazo, I guess, and your Tazosin. Of course, I don't care about the brand name. If you're talking about NCLEX, you think about generic name. Okay, it's very, very rare that the NCLEX is giving you brand names. They usually give you in your questions generic names. Okay, so piperacillin, tazobactam, like I said, this is also a beta-lactamase, which means to say it covers gram-positive and it also covers your gram-negative bacteria. So that's how strong your Sosin is, or your piperacillin and tazobactam. Look, now, if your patient comes in because of UTI, at the same time, your pneumonia, so can you give Tazocin for that patient? Can you give piperacillin plus your tazobactam to your patient? Yes, you can give, because again, this covers gram-positive and your gram-negative bacteria. Okay? So we're learning here, right? If your you know what, your piperacillin and your tazobactam is very effective to your what? Very effective to your Pseudomonas kind of bacteria. That's why sometimes it's called as an anti-pseudomonal antibiotics. Very effective to your Pseudomonas. Okay, so if your patient is resistant to this Sosin, the patient is still having some fever, the patient is still clinically not improving with that kind of infection, so it means to say the patient is resistant to that antibiotics. Okay, what's the next for your piperacillin plus your tazobactam? What do you think is next? Okay, what do you think is next? We have your carbapenems. Okay, your carbapenems are next. Okay, in a form of your meropenem. All right, in a form of your meropenem. Okay, there's what we call also as your astreonam. Okay, your astreonam. Nowadays, we have lots of astreonam. Okay, so astreonam. So we have two, the carbapenems and as well as your astreonam. Your astreonam is very good for respiratory kind of infection. In other words, these two here, respiratory, which means to say it could be because of your staphylococcus or streptococcus. All right, this is against gram-positive and as well as your gram-negative microorganisms or bacteria. Okay, again, Let's review on your gram-negative. Baseline is your amoxicillin plus your clavulanic acid, ampicillin, and your sulbactam as well. They are empiric because they have beta-lactamase. Okay, which means to say it covers gram-positive and as well as your gram-negative. Okay, give it a stronger one. Okay, give it a stronger one, which is your piperacillin plus your tazobactam. A stronger one for a sick patient. In other words, the patient is septic. They don't come to the hospital without fever. They don't come to the hospital if they're not, if they're feeling well. All right, that means to say this patient is sick. All right, piperacillin plus your tazobactam is with beta lactamase. That means to say it's a stronger antibiotics which covers gram positive and as well as your gram negative. If your patient is too much sick and then it's not responding to your piperacillin plus your tazobactam, you give that patient the highest form of these antibiotics on this side, on this side of the illustration, your aztreonam, at the same time your carbapenem. A stronger antibiotics if your patient is still sick, not responding to any form of treatment. Okay, so that means to say if you are familiar with your meropenems, these are strong antibiotics. Okay, and aztreonam as well. All right, so aztreonam and your carbapenems. Aztreonam is very good for chronic long-standing pulmonary infections. Okay, so this is on the other side of this, of this illustration. Let's take a look at on the other side. It's more on to the positive. It's more on to your gram positive. Let's take a look. We have what we call as your methicillin. Okay, have you heard the word methicillin? Have you given a medication in a form of methicillin? It's also a penicillin base, by the way. Have you heard this word? I mean, this medication, methicillin? Actually, you don't give this in the, I mean, you cannot see that in the floor, in the unit. They're only going to make use of that in the laboratory to see if the patient is resistant or not. Okay? So if the patient is sensitive to your, let's just put it blue, for a microorganism known as your methicillin sensitive Staphylococcus aureus. Look at this. I put the Staphylococcus aureus on your gram positive, okay, because it's gram positive, obviously. So they use your methicillin as a medium, again, like I said, to determine if the microorganism is sensitive or resistant. So there's two. It's either MSSA or methicillin sensitive Staphylococcus aureus, or the other one is your MRSA. Okay? So MRSA, let's move to that later, right? So your methicillin in a form of, for example, we have what we call of your as your napcillin. Okay? Your napcillin. So napcillin is effective to your what? Again, this is more onto your gram positive. Okay? So napcillin is effective to your methicillin sensitive Staphylococcus aureus. Okay? But it's not to your methicillin sensitive. Okay? Napcillin is an example of your, obviously, of your methicillin. Okay? There's also one, your oxacillin. All right? Your oxacillin, and as well as your napcillin, doxacillin. Your doxacillin. I guess nowadays we have napcillin and your doxacillin. I'm not sure about the oxacillin nowadays. But anyway, so those are methicillins that are given to a patient having a staph infection. For instance, wounds, non-complicated wounds, as long as it's not MRSA. Because like I said, MRSA is resistant to this baseline antibiotics, which means to say we need another antibiotics. And again, I'm going to put here your MRSA, which means to say this Staphylococcus aureus is methicillin resistant. We need to give a stronger antibiotics. What is the drug of choice? This is a very common NCLEX question. Drug of choice for a patient having MRSA. An MRSA can happen to everywhere. Skin infections, for instance, respiratory infections, It can be UTI or urine infections. It could be bowel infections as well or GI infections. So what's the drug of choice again? What's the drug of choice for your MRSA? Come on, guys. What's the drug of choice for your MRSA? You have your vancomycin. All right. The famous NCLEX thing is your vancomycin. I'm gonna put emphasis on this one. Okay, your vancomycin is a drug of choice for your methicillin-resistant Staphylococcus aureus. Okay, but please, vancomycin has a narrow therapeutic index. In other words, chances of getting toxicity is very high. Okay, this is the usual thing that they're gonna ask you in your NCLEX. So you always have to check for the therapeutic levels. All right. Again, like I said, it has a very narrow therapeutic index. In other words, chances of getting toxic is very high. And chances of getting toxic, which means to say toxicity, which organ in your body that you can associate with toxicity? Come on. So, they're going to ask you about that always. It's a matter of safety, guys. Okay. It's a matter of, safety of your patient. And NCLEX is always going to ask you about safety. All right. So, toxicity. So, you're going to check for the therapeutic levels, which is about 10 to 20. Okay. All right. And as well as check for your what? Kidneys. Very good. It's very nephrotoxic. Mycins, especially your vancomycin. So check for your BUN and as well as your creatinine. Okay, your BUN is about 10 to 20 as well, and creatinine is about 0.5 to 1.5. Okay, so check for the kidney function, the BUN and creatinine. Okay, how are you going to check it? Okay, of course, lab works. At the same time, check for the therapeutic levels. In other words, if the therapeutic levels is too much, I mean, it's too high. That means to say it's becoming toxic to you. I mean, the levels are too high to your BUN and creatinine. That means to say it's very toxic to your kidneys. They're gonna adjust the dose. Going back here to your indication. So your vancomycin is the drug of choice for your MRSA. If the patient is still sick, what do you expect you are going to give? Come on. Those people that are working in the hospital, if your vancomycin is not working, the patient is still sick, the patient is still having fever, what are you going to give? Come on, guys. What are you going to give? What are you expecting from the doctors to give? There you go. So, what's your answer? Any idea, guys? Any idea? So your vancomycin is not effective anymore. It could be a form of your, like I said, we have enterococcus here. So we have VRE, vancomycin resistant enterococcus. Okay, vancomycin resistant enterococcus. It could be vancomycin resistant Staphylococcus aureus. So these are the strong microorganisms that I'm talking about. Okay, they are even resistant to your vancomycin. They are even resistant to any forms of antibiotics. So you go higher, okay, in a form of linezolid. Okay, in a form of linezolid. Make it white, of course. In a form of your linezolid. The most common brand name to this is Zybox. Okay, Zybox. This is a very expensive medication because it's a higher form of antibiotics. Okay, for a higher form of microorganism. So, can you give linezolid for a patient having simple colds? Definitely, that patient will develop some form of antibiotic resistance. You know what I mean? Linezolid. Okay, this is very good for respiratory kind of infection. Respiratory kind of infection, those patients who are having hospital-acquired pneumonia, linezolid is very effective. There's another one, your daptomycin. All right, your daptomycin. Daptomycin is a higher form of, they are two different things from your vancomycin. I guess your vancomycin is glycopeptide, and your daptomycin is some form of a lipo, something peptide. But anyway, daptomycin is good for bacteremia. Okay, in other words, it's spread out. All right, it's everywhere. For example, I'm gonna tell you what's the easiest. I mean, what's the condition that can easily cause bacteremia? So this is for bacteremia. Okay, so for bacteremia, okay, daptomycin. What are the infectious conditions that can easily cause bacteremia? Endocarditis. This is very good for endocarditis, guys. Endocarditis is also caused by what? Staphylococcus infection. That's why it's in your gram-positive. Does that make sense? Okay. So they are actually considered as, as a broad spectrum antibiotics. In other words, it can cover gram-positive and it can also cover gram-negative. However, they are more effective to your gram-positive microorganisms. Okay, they are more effective to that. So that's why I'm gonna put it here on the, on your gram-positive. Vancomycin is not broad spectrum. It's very good for MRSA. However, it doesn't cover your E. coli, your Pseudomonas, your ESBL, and your Klebsiella. It's very good for staph infections, especially your methicillin-resistant Staphylococcus aureus. All right, are we learning here? I'm going to stop here. Antibiotic ladder. I'm not going to finish my lecture, guys. I still have some antibiotics to discuss. Okay. Like I said, it's a ladder, one step at a time, just like your NCLEX. Okay, you'll have to learn many things in your NCLEX before you will achieve the passing, standards. All right, but it's challenging. In order for you to surpass your challenges, guys, you always have to deal with it one step at a time. Here I go again. I'm giving some thoughts to you guys. One step at a time. And please don't stop until you will be proud to yourself. Take note, quote unquote. Please don't stop. Don't stop until you will be proud to yourself. That means to say, you do it one step at a time, one day at a time, until you master, the concepts, and you'll be able to, achieve this goal. Okay, that's one thing, huh? That's one thing. I can probably give you some words of wisdom as I go along. Let's go to your what's the cephalosporins? Yeah, I'm gonna write here cephalosporins. Okay, I'm just gonna write ceph. All right. So cephalosporins. Still considering your gram positive and your gram negative. I'm gonna put your. I'm gonna make it yellow, I guess. Your third generation in the middle. Your fourth generation, and as well as your fifth generation cephalosporins. I'm going to put here your second generation, and here is your first generation. That means to say that your first generation and your second generation are good for gram-positive microorganisms. Okay? In a form of your, I'm going to make it right, or yellow, still yellow. Your basic cephalexin, right? Your basic cephalexin. I think your second generation is your cefuroxime. I'm just gonna write cefu. Okay. And your third generation antibiotics, which is very common here, ceftriaxone. All right, ceftriaxone. I'm gonna put emphasis in your ceftriaxone as well. Ceftriaxone is very common. You know why? Because if you look at this here, it covers both gram positive and as well as your gram negative. Now, if your patient is having UTI, for example, at the same time having pneumonia, so ceftriaxone covers both. Unless if your patient has some form of another infection that makes him really, really sick, you can add another antibiotics. That's why you can see ceftriaxone and as well as your Zosyn or your piperacillin tazobactam. Did you get that? So your fourth generation, I guess we have your cefepime or cefepime. Let's make it yellow again. Your cefepime is a fourth generation. These are just the examples of your first, second, third, fourth, and fifth generation. We also have your fifth generation, your ceftaroline. Okay, your ceftaroline. Are you learning here? Can I say yes from there? Okay. So first generation is cefalexin. That's the most basic. It's more onto your, I would say, it's more onto your gram positive. And when you say your cefuroxime, the same way as your cefalexin, your third generation in the form of your ceftriaxone, which is to both gram positive and as well as your gram negative. Now, if you look up, you look at your fourth generation. Look at your fourth generation. Your fourth generation is more on to your gram negative. Okay, it's more onto your gram negative. The same way as with your ceftaroline. It doesn't mean that they are fourth generation or fifth generation. It doesn't mean that it covers everything. Okay, it doesn't mean that it covers your gram positive and your gram negative. There are some microorganisms that are covered, but it's more on to your what? It's more on to your gram-positive. Shall I just put it this way? I'm gonna make a bar, something like this. All right. So your first generation and your second generation, it's more on hyped. I like the word hyped. It's more on hyped to your gram-positive. I'll put here gram-positive, and it goes down in here and into your gram-negative. So this is basically your gram-negative. So the same way, vice versa to your fourth generation and your fifth generation. So it's more onto your gram-positive. Sorry about the visuals. It's more onto your gram-negative. Sorry, and lesser coverage to your gram-positive. So what's the safest antibiotics here? Your ceftriaxone, because again, balance covers what? I'm looking like dancing here. It covers gram-positive and as well as your gram-negative microorganisms. That's why it's given for a patient having UTI with E. coli, okay, and as well as your, gram-positive with pneumonia, for instance. Does that make sense? Okay. So this is your cephalosporins. Okay. What about your, what's this? If you're into baseball and you know this, this is your first base, this is your home base, and this is your second base, and this is your third base. I'm talking about your fluoroquinolones. All right, your fluoroquinolones. What are the examples of your fluoroquinolones? Those antibiotics with a suffix with flo, ciprofloxacin, for example. All right, so ciprofloxacin, there's a flow on it, in the middle, ciprofloxacin. So that's one example. All right. And secondly, we also have your levofloxacin in the form of your levaquin, levofloxacin. All right. And lastly, your moxifloxacin. Again, there is, am I correct with the spelling? Moxifloxacin. There you go. There is flow here. That's how you remember the fluoroquinolones. Of course, I'm not going to talk about the mechanism of action. That's already pharmacology, guys. I'm just telling you what's the coverage, of these antibiotics. All right, look at your ciprofloxacin here. I'm going to write, it's more onto your gram-negative, okay? This is more onto your gram-negative. It means to say ciprofloxacin is good for your UTI as well. What did I write here? E. coli. All right, that's good for your UTI. All right, because E. coli is the most common cause of your, most common cause of your UTI. So it's good for your UTI because it's more onto your gram-negative. Okay, so this is your gram-positive as well. Moxifloxacin, for example, if your patient is having some form of a skin infection, your moxifloxacin is good. What's good about your moxifloxacin is that it's PO at the same time an IV form. Okay, a levofloxacin, for instance, is also PO in an IV form. Ciprofloxacin is in a form of PO. Okay, if your patient is not toxic, not coming to the hospital and having UTI, it's not sick, they can go home with ciprofloxacin. Okay, so let's talk about that later in terms of the common infections. Just a quick overview. What are the common antibiotics given for a patient having this kind of infection? It's gonna be quick. As long as we already presented this illustration, and then you will know what kind of antibiotics to be given considering your gram-positive and gram-negative as well. Okay, and I'm gonna draw a person here. Okay, I'm gonna draw a person here. Okay, so this is related to your anaerobic microorganism. All right, if your patient is developing some form of anaerobic kind of infection, which is brought about by microorganisms that can live in an environment without oxygen. For example, I would say staph. Staph infections or staph microorganisms can live also on an unoxygenated kind of environment. Okay. On the other hand, the common what? The common C. diff. All right, your C. difficile, your Clostridium difficile. It's very common. It's a very common also question in your NCLEX. Okay, for example, your staph, your C. diff, and as well as your E. coli. These are the common ones that can live in an unoxygenated kind of environment. Okay, what's this person doing here? Okay, if you have, for example, this is GI, all right, in your tummy, all right, and as well as in your genitourinary, so GUT. Okay, if you have this GI and GUT kind of infection, let's say reproductive or gynecological kind of infection, metronidazole is the drug of choice or the antibiotic of choice. All right. So in other words, if your patient is having some form of bowel infection, okay, most of the time it's E. coli, it's anaerobic. If you see your patient having some form of bowel infection, GI infection, give, you expect your doctor to give metronidazole in a form of your flagell. Okay, in a form of flagell. For example, if you have some gynecological infection, you expect your doctor to give metronidazole as well. Okay? Other than that, other than your, let's make it blue, sorry, other than your GI and your GUT, skin, for example, other than these sites, other than this blue color here, you give your clindamycin. Okay? Your clindamycin. Okay? Your clindamycin, for example, if you have a pimple, that's outside of your GI, that's outside of your genitourinary, or that's outside of your, your gynae. Clindamycin is good for what? Pimples. Okay? Staphylococcus. It can be because of your staphylococcus. Okay? I don't believe that it's caused by an E. coli and something else. Where can you find your E. coli? From your poops. All right? So, well, it's usually staphylococcus. Okay, so you give clindamycin because staphylococcus can be an anaerobic kind of microorganism. What did I say? It's either metronidazole or your clindamycin. Are we learning so far? Okay, so let's take a look at this one. See, we have covered your penicillin, your cephalosporins. We also covered your fluoroquinolones, your penicillin, your cephalosporin. We covered your fluoroquinolones, and as well as your what else? Antibiotics, which are very specific to your anaerobic kind of bacteria. For example, your staph, C. diff, E. coli, metronidazole. Now, if your patient is having some form of C. difficile, what's the drug of choice? C. difficile. What did I tell you earlier? It can cause bowel infection. All right? Here, look at this one, your C. difficile. Sometimes we call it as your colitis. All right? Colitis. All right. All right. C. diff colitis. We call them as your C. diff colitis, which is, colitis, infection to your bowel related to C. diff. It could be because you're getting lots of antibiotics. That means to say that your C. diff is an antibiotic resistance kind of microorganism, which means you can acquire that to the hospital by getting too much antibiotics. Okay? Your C. diff colitis. What's C. diff here? Is it gram negative or gram positive? Come on, guys. What's C. diff? Gram positive, gram negative. Where did I put that? Here in your gram positive microorganism. At the same time, it's anaerobic. Okay, so what's the drug of choice by then? If you're having C. diff, your metronidazole because it's in your GI. It's colitis. Okay. At the same time, can you give vancomycin to that patient? Yes or no? Can you give vancomycin for a patient having C. diff colitis? Metronidazole, yeah, yes, that's correct. But my question is, apart from your metronidazole, can you give some form of another antibiotics? Can you? C. diff is what? Gram positive. Can you give vancomycin to that patient? Yes. So for a vancomycin patient, you can give metronidazole. It's also an NCLEX thing, guys. Metronidazole. At the same time, you can also give, not in a form of IV, because vancomycin can be in a form of PO as well. So just PO vancomycin in a form of like a syrup, right? So vancomycin, at the same time, your metronidazole, these are the drug of choices for your C. diff colitis. And of course, if you have like colitis, you will have some form of diarrhea, because it's inflamed, it can trigger some form of diarrhea. Okay, so it's gonna be like, smelly. You can really know, this is C. diff. All right. So you may, you may recommend to the doctor, oh, it looks like C. diff, and I'm gonna save some specimen and to confirm that this is really C. diff colitis. Okay. So let's move on to the common infections. If you have community-acquired pneumonia, are you getting me here, guys? We're almost done. No, not yet. Community-acquired pneumonia. Community-acquired pneumonia. So it's supposed to be, when you say like community-acquired pneumonia, from the word itself, community-acquired pneumonia, you acquired that from the community, not from the hospital. It's either hospital-acquired or community-acquired. Community-acquired is acquired outside the hospital. Okay? So community-acquired pneumonia. So what do you expect this patient will get? Okay. These are non-toxic patients. They can go home, right? What did I tell you? Streptococcal, for example, staphylococcus, for instance, it can cause pneumonia as well, right? And community-acquired pneumonia, it's mostly gram positive. Okay, so what do you expect? If you want to give PO, well, this patient can also take azithromycin. Let's add another antibiotics here. Your patient can take azithromycin. Azithromycin can be in a form of IV and PO. If the patient is outpatient, patient can go azithromycin. Pneumonia, which means to say the patient is already developing fever at the same time some form of a cough. It's most likely, bacterial kind of pneumonia, which azithromycin can cover. Okay, IV. Uh, Azithromycin can be in the form of IV if the patient is an inpatient status. Okay, so inpatient. So azithromycin can be given to a patient who is outpatient, ambulatory, at the same time as an inpatient. Okay, as an inpatient. All right, that's your azithromycin. Now, if your patient is, you can also give some form of moxifloxacin. Moxifloxacin. What did I tell you? Moxifloxacin is more onto your gram-positive as well. So it covers your pneumonia, community-acquired pneumonia. Okay? So moxifloxacin can be in a form of PO and as well as your IV. Okay? So if the patient is outpatient, the same thing. You can give PO as well. But nowadays, what we normally give is your azithromycin instead of your moxifloxacin because they found it more effective than your moxifloxacin. Now, let's take a look at your, uh, let's see your hospital-acquired pneumonia. Okay, your hospital-acquired pneumonia. Your hospital-acquired pneumonia is basically coming from a strong microorganism. Okay, a hospital-acquired pneumonia can be in a form of, for example, Klebsiella. I'm gonna make it blue, guys. Can be in a form of Klebsiella. What did I tell you earlier? Klebsiella is found is a strong, microorganisms in the hospital. Okay, because the housekeepers are not cleaning that much. I'm not blaming the housekeepers, guys. I admire their job. Like, these are really uh, kind of job na kailangan nating appreciate, that we need to appreciate. Sorry. Klebsiella. Klebsiella. What else? You can have MRSA. Okay, causing pneumonia. You can have Pseudomonas. All right, and everything else. You can have ESBL. Okay, you can have ESBL as well. You can have streptococcal, the most common form of pneumonia as well. Okay, so ESBL, Klebsiella, MRSA, Pseudomonas. You can also have your, let's say for example, your VRSA, your vancomycin-resistant Staph aureus. Now, that means to say, hospital-acquired pneumonia, that means to say that your patient is toxic. Your patient is septic. Your patient is sick. Okay? So you need stronger antibiotics, stronger than your moxifloxacin, stronger than your azithromycin, stronger antibiotics. They usually combine it. It's a combo. All right. And you can give what? Most commonly, you can give so basing on our illustration, what can you give that covers both? Going back to your community-acquired pneumonia, can you also give some amoxicillin? Yes, why not? Your amoxicillin. Yeah, that can be okay. Plus, as long as with clavulanic acid, that's fine because that covers both gram-positive and as well as your gram-negative. Amoxicillin, plain amoxicillin, no. You should have clavulanic acid on it your amoxiclav, because it covers, again, gram-positive, which is most commonly, your streptococcal. Okay, so your amoxiclav. Okay, going back here in your hospital-acquired pneumonia, what we usually give is your pipiracillin. All right, your pipiracillin plus tazobactam. Because, again, it covers what? Covers gram-positive and as well as your gram-negative. Okay, remember, it could be because of BSBL. All right, it could be because of Klebsiella, which is gram-negative. All right, this is gram-negative. It could be because of staph infection, which is gram-negative, which means to say your pipiracillin plus your tazobactam covers gram-positive and your gram-negative. You are safe to that, and it's a very strong antibiotics. If you look at the ladder, it's almost at the top, right? Okay. If your patient is, for example, is not responding to your pipiracillin, what did I tell you? Meropenem, carbapenems. Okay, and your aztreonam, because it covers, it covers also your gram-positive. And who knows, it's because of your Klebsiella as well, because your patient is, on a ventilator. Okay, that's the reason why you're having your aspiration. This is the very reason. I mean, this is the microorganism that can be blamed if you have some form of pneumonia coming from a ventilator, your ventilator-associated pneumonia as well. Are we learning so far? So pipiracillin. Can you add up different antibiotics? Yes, you can add up vancomycin. All right, you can add up vancomycin. Can you also add, for example, your pipiracillin plus tazobactam plus your ceftriaxone? Why not? Okay, your ceftriaxone. Your ceftriaxone is a cephalosporin. What did I tell you about ceftriaxone? It both covers your gram-positive and your gram-negative as well. Because again, considering these microorganisms, it's either gram-positive and gram-negative as well. Most common questions as well in your NCLEX. You always have to, get the culture first before starting the antibiotics. It's a very simple, it's a very basic, knowledge. Before you start any antibiotics, please get your culture. And some hospitals are still not following those very, basic uh, instructions. I would just call it instructions. A basic concept. Whenever you start antibiotics, make sure that you got your cultures already. I'm talking about your blood cultures. I'm talking about your sputum cultures. If your patient is having some respiratory infections, you get your urine culture as well before starting any antibiotics. Okay? So for a patient having hospital-acquired pneumonia, these are the things that you need to know. They are sick. You can give stronger antibiotics. If your patient is not responding to these kinds of antibiotics, again, you can escalate linezolid. Look at this one. Look at our illustration here. You can give daptomycin. You can give linezolid, but between, talking about still your hospital-acquired pneumonia, but between your daptomycin and your linezolid, I'll go with your linezolid, okay? Because linezolid is more to your respiratory, okay? Now, if you got your culture already, and it's Klebsiella, okay? Linezolid is still okay, but it's not. It's more onto your gram-positive. But you can add up another form of antibiotics in the form of pipiracillin, because pipiracillin is good for your Klebsiella. All right, so it covers, Klebsiella definitely. Okay, but you cannot give an antibiotics, an amoxicillin, co-amoxiclav for a patient having Klebsiella, because it's a very strong kind of microorganism. It has to be a strong antibiotics as well. And definitely you cannot give your daptomycin, linezolid for a simple colds. All right, or let's say, for example, uh, your community-acquired pneumonia, because these are very strong antibiotics. This is the very purpose of this antibiotic ladder. Did you get that? Okay, let's take a look at other forms of infection. For instance, we have your UTI. Okay, you have your UTI. If your patient is, let's say, for example, is pregnant. Okay, pregnant. Pregnant women should get amoxicillin. That's very safe. Okay, amoxicillin. Uh, Well, if your patient is having some form of fever, for example, you can add up with your beta-lactamase. For instance, because this is UTI. UTI is mostly common, which is mostly caused by what? Your E. coli. All right, your E. coli. All right. So E. coli, this is a gram-negative microorganism. So amoxicillin is fine. All right. If your patient is developing fever, and then okay, this could be another form of microorganisms. So I can give clavulanic acid, which means to say your co-amoxiclav. Did you get that for pregnant women? Amoxicillin is the base antibiotics for a patient having, pregnant. It's a safe antibiotics for patient having, a pregnant patient. Okay. For a woman having UTI, which is common to women, okay, I would say your nitrofurantoin, right? Your nitrofurantoin. Have you heard your nitrofurantoin in a form of your macrobid? Okay, you normally see that for a patient having women who's having UTI, but not necessarily pregnant. Because if you're pregnant, again, amoxicillin. Okay, so women, nitrofurantoin. I'm not really sure what's the study. What makes the women more responsive to nitrofurantoin instead of your trimetoprim, trimetoprim, sulfamethoxazole. The bad thing about it is that in the US, there's lots of sulfa allergies. That's why they don't much give trimethoprim. Instead, they're giving ciprofloxacin. So this is very universal. Your ciprofloxacin, okay? Your ciprofloxacin. So what is this trimethoprim sulfamethoxazole, or also known as your Bactrim? Have you got this medication before? Okay, so this is usually responsive or usually very effective to a patient having, as long as the patient is without ESRD. Okay, as long as the patient is without ESRD or without renal disease, trimethoprim is very effective. Okay, that's your Bactrim. Okay, but the thing is, like I said, there's lots of people here that are allergic to sulfa. Okay, because it contains sulfonamides as well. So again, that's your Bactrim. That's very good for a patient having UTI as long as the patient is without ESRD. Okay, as long as the patient is without ESRD. Ciprofloxacin for any kind of UTI. If you think about it, as long as it's not pregnant, and it's also responsive to women. Okay, ciprofloxacin is very good. So let's just put it here, outpatient. They can take it PO. They are ambulatory. They are not really sick. If the patient is sick, for example, and then they came to the hospital, okay, because they have a long-standing, for example, like Foley catheter, that makes them really sick. Okay, so what can you get from the catheter? There's lots of them. It could be gram positive, it could be gram negative. That's why, from a Foley catheter, this is basically your catheter associated urinary tract infection. So these are another, antibiotic resistance kind of condition. You can get it from, hospital. This means to say that these patients are sick. You get your ceftriaxone. All right, your ceftriaxone. Can you also get your levofloxacin? Levofloxacin. Yes, you can also get levofloxacin because levofloxacin, if you look at the baseball here, first base, second base, it both actually covers gram positive and your gram negative, but it's more onto your gram negative. So it means to say it covers gram negative. You can give that to a patient having UTI. Okay, ceftriaxone and levofloxacin. Now, if your patient is really sick, can you add up something apart from your ceftriaxone? Why not? Your piperacillin. Can you add that? Yes, piperacillin is a very strong antibiotics for what? For a sick patient, gram negative or gram positive. And who knows? That UTI is already coming from MRSA. Remember, MRSA is Staphylococcus is gram positive. So, does your piperacillin covers gram positive? What did I tell you? It covers gram negative and as well as your gram positive. That means to say your patient is safe as long as the patient is sick having UTI. How do you know if the patient is sick? Coming from a UTI, your patient is having fever, your patient is developing some hypotension, and who knows, it's already septic shock, right? Your patient is already confused, which is very common to an elderly woman here. I don't know what's the relation between the brain and the bladder, all right, for that matter, why they're confused. But anyway, So these are the common antibiotics given for UTI patients. That makes them sick as well because they're already confused. These are signs of impending sepsis. All right. And again, like I said, who knows? It's already septic shock by looking at your blood pressure, which is also already going down. All right. Are we still learning, guys? So your cotrimoxazole, yeah, that's they're also giving that here. Okay. But these are the usual things that we're giving here in the US. Okay. So again, most commonly, as long as the patient is not really sick from that UTI, we give your ciprofloxacin. If the patient is developing fever, you would think that it's already ascending. It means to say it's not, because when you say like UTI, it's supposed to be only in your bladder, cystitis. If it's recurrent, it means to say it's already ascending to your kidneys. It can develop pyelonephritis. That's the very reason why you're having fever and chills as well. You are sick. You need to get stronger antibiotics. If you don't have a fever, you don't necessarily get ceftriaxone. You can only get like ciprofloxacin. You can get, for example, your Bactrim. You can get, for example, for women, you can get your Macrobid or your nitrofurantoin. All right. So, well, these are the common infections. I may add some form of, let's say, for example, your wound infections. Okay. In here, what did I tell you earlier? I told you earlier that hospital-acquired infections, community-acquired infections, hospital-acquired infections for me are, it's overrated. Practically speaking, because you see patients having hospital-acquired infections already. I would say like underrated. Because even if the patient is just confined in a hospital for less than 24 hours, that microorganism is, that kind of microorganism is supposed to be acquired in the hospital. However, in the community, it's already present. They come to the hospital with MRSA. Okay? So, wound infection. So, I would say that it is MRSA. Okay? MRSA. Consider that as an MRSA. That's why. And then they come to the hospital who are sick. In other words, these are toxic patients, which means to say they can be septic, right? So, what's our medication of choice for wound infection? Okay, are you getting me here? They come to the hospital, they are very sick with wound infection, with cellulitis. To be specific, guys, with cellulitis, that's most likely MRSA. All right? They were not able to take care of their wounds. They acquire stronger microorganisms, which needs stronger antibiotics as well. Vancomycin. There you go. Vancomycin. So if you see your patient, it is very common also to your NCLEX. And I always see that, from day to day of my job in the US here. By the way, I'm working in a medical surgical telemetry floor. Well, I don't handle patients though. I'm a regular charge. Anyway, vancomycin is a drug of choice for MRSA. Like I told you earlier, again, if the patient comes into the hospital sick, looks like septic, with that kind of wound, consider it's MRSA. What's the drug of choice? Vancomycin. All right. Sometimes the patient is it's been recurrent, and for the fact that MRSA is a resident. If you had MRSA before, most likely, if you had some form of wounds, you can have, it's the same thing. You can have MRSA on the second time around. You will have wound because they are residents. It will stay in your body. I'm gonna tell you guys because these are stronger, kind of microorganisms. The drug of choice is vancomycin. Can you add up some more? Yes, you can add up piperacillin. That's fine. Okay, piperacillin covers what? Gram-positive and gram-negative as well. Staphylococcus aureus. Okay, but this is resistant anymore to your napsilin, resistant to your doxacillin, resistant to your what's the other one? Anyway, so resistant to those methicillins. Okay, so MRSA. So you give something else which is stronger because again they are sick. Okay, so I guess no more questions. Do you have any questions, guys? That's all for today. If you want to repeat the discussion today, it has to be posted in Connetics. to see, at least to review, because I'm always telling my students as well in Ipass that repetition is always the key. You master, you master things, you master stuff by repetition. Okay, whether you like it or not, you will agree to my opinion. In everything that we do, we have to master. And not necessarily everything that we do, especially in conquering this NCLEX. You have to master the concepts. You cannot master, I'm talking about the NCLEX, guys. You cannot master the concepts if you don't repeat it. So it's the key to your success in your NCLEX. What did I tell you earlier? Don't stop until you get proud to yourself. All right? And one thing for sure also, persistence. Okay? Persistence. You have to push through. All right? And if I can remember from the famous Jim Watkins, a river cuts through a rock. You know the river, right? They cut through the rock, not because of their power. It's not because of their power. Water is not as powerful as what you think. To cut through that rocks. If you see some rivers, right? They have lots of rock formation in there. However, it's not because of their power, but because of their persistence. Again, like I said, a river cut through rocks not because of their power. They cut through rocks because of their persistence. Okay, and it seems like the rocks are really, hard, but with your persistence, you are able to get through those rocks, those adversities, those struggles, and you'll be able to say, yes, I made my NCLEX. Okay, and God bless everyone. Of course, you have to be guided by the man above, the Almighty, in order for you to do, this stuff. God bless you all and have a good one. Okay? I guess there's no more questions, I guess. And hope you like my lecture today. Like I said, you can see the recorded version, posted in Connetics as well. If you're in Ipass, you can also see that in your Ipass page. Have a good one, everyone. God bless. God bless. God bless. Thank you, Miss Milanes, for this opportunity. Connetics, all in all, for this opportunity. Okay, thank you. Thank you.